بسم الله الرحمن الرحيم. الحمد لله رب العالمين. صلى الله وسلم وبارك على نبينا Muhammad. Welcome back to our sessions on pathophysiology of congenital heart disease. We finished most of the parts we needed to talk about. We're finishing today, inshallah, with pathophysiology of left-sided obstructive lesions, namely the mitral stenosis, aortic stenosis, and coarctation of the aorta. We will be talking, first of all, about mitral valve stenosis, and we can divide mitral valve stenosis into mild, moderate, or severe. When we talk about grading mild, moderate, or severe, we usually grade it by mean pressure gradient, MPG, which we measure across the pulmonary valve, whether in the cath lab or by the most common procedure, which is the echocardiogram by Doppler. So if we have mild mitral valve stenosis, regardless of the congenital cause of that mitral stenosis or the association, we're not talking about structure or causes, we're talking about pathophysiology. What does this lesion cause as a pathophysiological effect? So mild mitral valve stenosis, we are talking about a mean pressure gradient of less than or equal 7 millimeter mercury. Okay, so we're talking about a mean pressure gradient of less or equal 7 millimeter mercury. If the gradient is less than 7, then the condition is deemed mild. We have said before that our mean left atrial pressure, normal, is around 6 millimeter mercury. So we would expect in a mild mitral valve stenosis, we expect that the mean LA pressure will be around 13. Okay? So if we have a mean pressure of 13, which means we have about a 6 gradient. If we take the top being mean of 7 here, and this is 13, then we have about a 6 millimeter gradient. We know that our pulmonary artery pressure, or the pulmonary venous pressure here, these are the pulmonary veins coming in, the 4 pulmonary veins. The pressure in the left atrium, if we said it's mild, and it's now 13, mean of 13 millimeter mercury, the same pressure will be also here, mean of 13 millimeter mercury. What is the pressure in the normal pulmonary artery, PAP? A normal pulmonary artery pressure mean will be around less than 25, and most likely it will be around 15 millimeter mercury. If we add the difference, which is the 6 millimeter mercury, to that 15, it may be 25. If we take the higher normal mean PA pressure being 25 and we add the 6, the PA pressure will be, in a mild mitral stenosis, will be maximum mean of around 30 millimeter mercury, which is just above the normal by 5 millimeter mercury, or maximum by 10 millimeter mercury. This mild elevation of pressure in the left atrium, mild elevation of the mean pressure in the pulmonary arteries here. This is the left pulmonary artery. This mild elevation, I'm going to take away the drawing, you don't need it. You can just follow it by talking about it. So the mean pulmonary artery pressure here is mildly elevated. This combination is not expected to cause significant pathophysiological effect other than just the numbers being higher than normal. So if we look at the left atrium, do we expect it to be dilated or abnormally dilated compared to a normal person? Usually, no, not much of LA dilatation is seen. If any, it could be very trivial. So no effect on the size of the left atrium. What about cardiac output? Since this is a stenosis, it's supposed to be hindering cardiac output. But we know it's only mild, and the physiology is getting over it by elevating the pressure in the left atrium, so it can be, the blood can be squeezed in or ejected in from the atria of the left atrium to the left ventricle. By this, cardiac output should easily go in with no hindering. So we do not expect any cardiac output limiting effect. So no limitation on cardiac output. What about left ventricular size and function? We know that left ventricular function or ventricular function in general is dependent on the myocontractility, but also is dependent on volume loading. If you have good volume loading, you have good function, but if you have poor volume loading, you may have poor function, which after loading the ventricle will actually prove that it was not poor. It was only just underfilled ventricle. So we do not expect an effect on cardiac output, nor do we expect any effect on LV systolic, diastolic, or size. Function and size are also quite maintained in mild mitral valve stenosis. Do we expect any congestive heart failure because of isolated mild mitral valve stenosis? No, we do not expect any cardiac failure of any sort, not systolic, not diastolic, not combined. Do we expect any arrhythmias because of that? Since we do not have a severely elevated pressure and no chamber dilatation, especially no left atrial chamber dilatation, we also do not expect cardiac arrhythmias in such patient, unless there are other associations with this congenital mild mitral stenosis that predisposes to any additional complication. But again, if it is just mild, we do not expect, and this is the paradigm that's going to happen. What if it is a moderate stenosis? And when we say moderate, that means the mean is anything between 7 millimeter mercury and less than or equal to 12. That's a mean pressure, huh? Mean pressure difference of anything between 7 or above 7, because it was equal 7 in the mild, to less than or equal 12 millimeter mercury. Obviously here, if we practice the same exercise we are doing throughout, let's take that it is actually 12. So with a mean normal LA pressure of what, 6? Yes, that's what we have said. Then we expect that the left atrial pressure in this patient will be around 18 mean. You see, the mean here will be 18 millimeter mercury, and that's a much higher pressure. The same will go that we will actually now see a mean of 18, again, also in the pulmonary veins, okay, reflecting the high LA pressure. A mean of 18 compared, if we take the gradient now, we said the gradient before was around 6. If we take the gradient now, it's what? It's 7 minus 18. Now the mean gradient is around 11. So it's anything between what we said as moderate. Let's say it's a 10, just to make it simple. So moderate, we have a mean gradient of 10. We know that the PA pressure normal is about 15 to 25. We chose last time to take the higher number, 25. So 25 plus the mean of 10, then your PA pressure in a moderate mitral valve stenosis, mean PA pressure will be around 35 millimeter mercury. You see? Now we are in the moderate PA pressure, knowing that a mean of 50 in the pulmonary artery pressure is considered high or severe. So normal is around 20, high is around 50, mean PA pressure, a mean is around 35 pressure. In this stage, you see the mean LA pressure now, which was 6, it's now 3 times its normal pressure. And as a rule in cardiology general, any size or pressure or diameter that increases by 2.5 to 3 times its original size, then this is a significant change. And that's why here, because of this mean LA pressure of 18, we will start seeing at least mild to moderate left atrial enlargement. So there will be here left atrial enlargement, yet it is not severe. It could be mild, maximum moderate left atrial enlargement because of such moderate mitral valve stenosis. Let's move now to the next point. Cardiac output, will it be affected? Obviously no, because we haven't reached a stage where the right ventricle cannot pump the blood to the pulmonary artery pressure because of pulmonary hypertension, nor did we reach a stage where the left atrium is so dilated and dysfunctional that it cannot actually squeeze the blood in diastole to the left ventricle. So cardiac output, even in moderate mitral valve stenosis, will be maintained. So no effect. When I say X, it means no effect. It doesn't mean that the cardiac output is X, no. So no effect on cardiac output, it will be maintained. Left ventricular function and size are also maintained, no major effect. See, there's always a trivial effect because now we are at moderate, but no effect measurable. No effect that really makes a difference in cardiac output or cardiac function or size of the left ventricle. Do we expect any congestive heart failure because of moderate mitral stenosis? The answer is most likely no. Do we expect any cardiac arrhythmias because of a limited inflow through the mitral valve with a moderate mitral stenosis? Then here we could say plus minus. So it is possible, but not probable. Most likely you will not see arrhythmias in moderate mitral stenosis unless it has been really for a very long time and we have significant left atrial dilatation. Cardiac function also on the right side, we will not see any effect. We will not see cor pulmonale, we will not see significant pulmonary hypertension, but we may start seeing mild elevation of pulmonary artery pressure and right ventricular pressure. If a mean here is 35, we expect the systolic to be around 45 to 50. So your right ventricle in a moderate pulmonary  RV systolic I reversed it. RV systolic pressure will be what? Around 45 to 50 millimeter mercury, which is mildly to moderately elevated. Yet, no significant right ventricular hypertrophy, no significant dilatation, and no significant effect on cardiac output. This is mild, this is moderate. Now we go to severe mitral valve stenosis, and when we talk about severe, we talk about a mean pressure gradient difference between the left atrial pressure and the end diastolic left ventricular pressure of more than 12 millimeter mercury. We're talking here about a pressure difference of more than 12 millimeter mercury, more like 15 and so. So obviously here we are really reaching very high pressures, and we start seeing pathophysiological effects of such an obstructive left-sided lesion. Let's go to left atrial pressure. It was 13 in a mean of 13 in a mild, mean of 18 in a moderate. What do you expect it here? If we say it's more than 12, probably we'll take a mean of 15. 15 plus the normal 6, we will probably go now and start seeing a left mean atrial pressure of around 20 to 25, let's say it's 22, just for a number, millimeter mercury. Obviously now the difference is really getting higher, and you see it doesn't take on a venous side. The atria are non-muscularized in general, quote unquote, chambers, so they do not produce high pressures. So you only need a few millimeters to move from mild to moderate and moderate to severe. You see here, we just needed 5 millimeter mean pressure to move to moderate, and here we needed another 4 to move to severe, because it's on the venous side, on the atrial side. So if we say this is now mean of 22, and this is supposed to be the pressure, or the 6, we have a difference of what? 15 or 16 millimeter mercury. Add that to a normal mean pressure of around, let's say, we took before 25, so 25 plus 16, that's what? 41. It was here 35. Now it will go to 40 to 45 around, let's say. We said 41 millimeter mercury mean PA pressure. If we are going to add now the 20 to make it a systolic PA pressure, then the systolic PA pressure will be above 60, and obviously the right ventricular systolic pressure will also be more than 60 millimeter mercury, and this is quite high. If we take an average systolic pressure of 100, then this is about 2/3 systemic pressure, or above 50% systemic pressure, and now this is quite high, and now we really expect to see changes and differences. So LA size, we said there is mild to moderate LA enlargement in moderate mitral stenosis. Obviously now in severe mitral stenosis, there will be at least moderate to severe LA enlargement or LA dilatation. So left atrial dilatation is a main pathophysiological effect that we see in severe mitral valve stenosis, and it's going to be at least moderate, if not severe. And how we judge? By measurement, and we take compare it to what is expected normal for body weight and surface area, and we will know whether it's mild or moderate or severe enlargement. But it is severe enlargement. Cardiac output, yes. Now cardiac output can start being affected. It's not going to be affected in terms of being critically affected, but at least it will be moderately affected. When I say check sign here, it means it is affected. It doesn't mean it's good, huh? Just be careful. I'm using it in a bit different way. So the cardiac output is affected. We are going to start seeing less cardiac output, not to the critical stage where the blood pressure cannot be maintained, or the patient may develop symptoms of low cardiac output state at rest, but maybe develop it on exercise for sure. But here we are talking about that the cardiac output will start seeing limitations. Left ventricular volume and function may go down, so because of limited filling. So we do have an effect on left ventricular function and volume, and that's how in congenital mitral stenosis we may see actually hypoplasia of the left ventricle in utero or after delivery. And this is, again, if you really believe in the flow theory, because of limited flow going to the LV, and most of the flow will actually just go through the PFO to the right atrium, causing the smaller LV. So LV function, LV size is affected. LV EDP is not changed. Maybe it's lower, maybe it's higher if the cavity became smaller. So, but we don't care about that now. We're just talking about isolated mitral valve stenosis, severe form, affecting to some degree the cardiac output, limiting LV size and limiting LV systolic function. Congestive heart failure is a possibility. So again, we can start seeing congestive heart failure or cor pulmonale, and arrhythmia also can be seen, and it would be atrial arrhythmia, and most of this atrial arrhythmia will be either flutter or fibrillation because of the severely distended left atrium and loss of conduction pathways and dissociation of those conduction pathways between each other. And now we're going to see each focus just beating on its own, causing the flutter or the fibrillation of the heart. So if we take it further now we have pulmonary hypertension, because RV systolic pressure and PA pressure now, they have, the PA pressure will have a mean of at least 60. RV systolic pressure will be also at least 60. Now with longer time passing with such disease, we will start seeing right ventricular hypertrophy, reaching to all the complications of such disease called cor pulmonale. That means we can go from just simple RVH to RV dilatation, tricuspid regurgitation, low right-sided cardiac output, pulmonary regurgitation, increased systemic venous pressure and venous congestion with all its effect on the body, causing congestive heart failure. Obviously, when it becomes critical or near atresia, then this is the extreme example of mitral stenosis, where there will be significant pulmonary edema, cor pulmonale with it, and decreased cardiac output, severe enough even at rest. Just to finish, would we see pulmonary edema in mild mitral valve stenosis? No. In moderate mitral valve stenosis, very unlikely. In severe, yes, we will see signs of pulmonary venous edema, and actually we will see on the X-ray that the pulmonary arteries actually are enlarged and dilated, and even on echocardiogram. I hope by this I have summarized mitral valve stenosis pathophysiology based on mild to moderate and severe, and based on the mean gradient, the left atrial pressure, the pulmonary artery pressure, the LA size, the cardiac output, the left ventricular size and function, congestive heart failure, and arrhythmias. Can mitral valve stenosis, if it's critical, give us ischemia signs? Well, if the cardiac output is decreased, that's a possibility, but it is not a common possibility. It's actually extremely rare. But for sure, mitral valve stenosis, if critical, and if the baby is born with it, and it's really critical without a significant ASD and without the presence of a patent ductus arteriosus, we may go into cardiogenic shock as a pathophysiology in such rare, extreme situation of near atresia of the mitral stenosis. From this, we will move to subaortic stenosis and aortic stenosis. Welcome again. So we'll continue our pathophysiology of congenital heart disease, pathophysiology of left-sided obstructive lesions. Our second lesion here is subaortic stenosis and aortic valve stenosis. We'll start with subaortic stenosis. It's almost similar to aortic valve stenosis, but it has some additional characteristics to it that are a bit different than aortic valve stenosis. So subaortic valve stenosis is the stenosis in this area, in the subaortic area. If you can follow with me, this is the aortic valve, this is the mitral valve, this is the subaortic stenotic area. It can be due to so many mechanisms, like I drew here the membrane. It can be hypertrophy of the muscle, it can be fibromuscular, and it can be a tunnel shaped, and so many areas. It can be very close to the valve, far away from the valve, and even somewhere in the mid cavity. And so many causes for it. We're not talking about causes, we're talking about pathophysiology of left-sided obstructive lesion, and we will be talking now about mild to moderate to severe subaortic stenosis. Grading mild to moderate to severe subaortic stenosis by mean pressure gradient is not as clinically accurate as we want it to be, because we tend to not accept high gradients like in aortic valve stenosis to call them mild or moderate or severe. But just for the sake of the talk, since we have ran this theme, I will continue on the same theme and add the differences in between. So what is a mild subaortic stenosis mean pressure gradient? If one would choose a number, one would probably say anything less than or equal 20 millimeter mercury. That is a mild subaortic stenosis. Mean pressure of less than or equal 20 millimeter mercury. If we take that as a number, what is our usual systolic ventricular or left ventricular pressure? We took before a mean of 100 or a common number of 100. Let's continue on the same thing. If the gradient between the left ventricle and the aorta, because of the subaortic stenosis and our aortic pressure of 100, then the LV pressure in this stage will be, instead of here, LA pressure, we'll leave LA, but we'll go to the LV. LV pressure here will be around 120 millimeter mercury. Again, not a significant LV hypertension, because 120 is still within the normal higher side of LV pressure for a child, let's say, or an infant who is 1 year old and above. It may be on the higher normal or slight RV hypertension. So do we expect, with such mild pressure gradient difference, any pressure effect? Do we expect the left atrial pressure to be elevated? It's very unlikely that the left atrial pressure in mild subortex stenosis will be elevated, because your left end diastolic ventricular pressure, LVEDP, will still remain normal in such a mild subaortic obstruction. That means, let's say it's about 4 to 8, maybe 6, then our left atrial pressure will not change. It will not be affected. My X means that it is not affected. It is just within normal. If the LA pressure is within normal, we do not expect any effect on the pulmonary artery pressure. If the LA pressure is also normal, we do not expect any left atrial dilatation or enlargement in size. If it's only a mild obstruction, we do not expect any changes in the cardiac output. The left ventricle is still able to eject the same cardiac output with no change and no difference, even with exercise. And hence, we also do not see any congestive heart failure, and we do not see any arrhythmias. Do we see any left ventricular hypertrophy? Well, plus minus. LVH is a plus minus, and most likely it's not seen. It is a possibility, but probably no LVH at all. There is one caveat about this disease, which I will leave to the end, but I'm just going to finish what we call mild, moderate to severe obstructions. So let's go to moderate subaortic stenosis. We expect a mean of above 20 and less than, for sure, less than 50. So we're talking about a mean of 20 to less than 50 millimeter mercury. By the way, you may find that actually some would talk about mild, moderate to severe subaortic stenosis based on systolic pressure gradient, not mean pressure gradient in subaortic stenosis. And then we call a systolic pressure difference of less than 40 being mild, less than 60 being moderate, and more than 60 or more than 55 to 60 being severe. But here I'm talking about the mean, just to keep it simple for us to follow based on what we have done previously. So if now we have a mean gradient, actually for the sake of subaortic stenosis, I'm going to revert back to systolic pressure, because talking about LVH and so with a mean pressure, you may not grab it very well. I'll take it back. So here we are talking about a systolic difference of less than 30 millimeter mercury. Here, a systolic difference of less than 40 or equal to 45. And here we're talking about a systolic difference of over 55 millimeter mercury. And probably here, see, the numbers are not as accurate as you want. You may read it in different books differently. But let's say here, less than 50, and take away the equal, just to make it simpler. So again, if we take, just to go back, if the systolic pressure gradient is, let's say 30, you have an LV, an aorta of 100, then this is 130. It will not change much all what I have said. No left atrial pressure change, no pulmonary artery change. LA size is normal, cardiac output is normal, LV function and size is normal. LVH is a plus minus, no congestive heart failure and no arrhythmias. But if we move to moderate and we're talking about something more like a 50 gradient, then your LV pressure based on the 100 in the aorta will be actually 150 systolic. And obviously that's systolic hypertension in most ages and body weights. Maybe in elderly or older age, it can be considered as normal, but a 150 is systolic hypertension for sure. And once this is systolic hypertension, we could see effects. So let's talk about LA pressure. With a 150 that is not extremely long standing, we do not expect much change in the left atrial pressure, because the LV end diastolic pressure is most likely to be maintained unless this is a 150 chronic systolic hypertension, okay, with no diastolic hypertension. So the LA pressure is most likely going to be not affected, and hence the PA pressure is most likely not going to be affected. LA size, well, if we accepted that the LA pressure is not changing and the left end diastolic, ventricular end diastolic pressure is also maintained, this is not a very, very long standing systolic hypertension of the left ventricle, then left atrial pressure size should not be affected. And if the left ventricle is able to generate this pressure with a maintained systolic function, then cardiac output is also not affected at rest. And again, I'm saying here at rest, because with exercise, this moderate stenosis may become severe, and then we may see limitation of cardiac output. Congestive heart failure is not expected. Atrial or ventricular arrhythmia is also not expected in at rest measured moderate systolic pressure gradient of subaortic stenosis. So let's go to severe. If we are talking about more than 55, let's say it's 60, then we're talking about really significant LV hypertension. And here the LV pressure may go up to 160, 170. I'm going to write it 170 just to make it look like really significantly elevated, choosing a gradient of about 70 across the subaortic stenosis area. In this stage, left ventricular hypertrophy is a very likely possibility. So we will see LVH for sure. Here LVH is a plus minus 50-50, but here LVH is a plus, maybe plus plus. Okay, so very highly likely to happen. And once we start to have left ventricular end effect of such LV hypertension, we will start seeing some non-compliance and stiffness of the left ventricle and possibly elevated or abnormal LV EDP. Okay, we start seeing elevation of the left ventricular end diastolic pressure. And if this starts happen, then you can actually guess already with me what's going to happen. The left atrial pressure is going to be higher with the elevation of the end diastolic pressure. So we will not see that normal LA pressure, mean LA pressure of 6. It may be 10, 12, depending on how much left ventricular hypertrophy and how much elevation we have of left ventricular end diastolic pressure. So in severe, LA pressure is going to be affected significantly. Pulmonary artery pressure will depend on how high the LA pressure went and how high the LV EDP went to. If it is mild or moderate or severe, then the PA pressure may become mildly elevated, moderately elevated, or even severe pulmonary hypertension at reaching to the stage of possible cor pulmonale if left untreated. So PA pressure can be affected mildly or moderately in severe obstruction. So let's take a check sign. LA size, if we have moderate elevation of the left atrial pressure or severe elevation of the left atrial pressure because of moderate or severe left ventricular end diastolic pressure elevation, then LA size will also become enlarged. Cardiac output, as long as the systolic function is well maintained and as long as the EDP is not severely elevated and at rest, the cardiac output should be still okay. It will not be affected. But if the systolic function starts to depress, which is a possibility, and if the EDP is extremely high, or or it is not at rest, then the cardiac output can be depressed or decreased in these conditions of low function, systolic or diastolic, and in the case of significant exercise. Congestive heart failure is unlikely unless systolic function starts to depress, diastolic function becomes severely, moderately to severely affected with a very high EDP. We should not expect, even in severe, non-long-standing, non-associated with systolic dysfunction or diastolic dysfunction, and not at exercise, we should not expect congestive heart failure. Arrhythmias are a plus minus because here we do have left atrial enlargement, we do have left ventricular hypertrophy, and we have an EDP which is high, and we may have at exercise a low cardiac output. All of this can be a source of atrial or ventricular arrhythmia, whether it's because of direct effect of severe LVH or end diastolic pressure, or actually even coronary insufficiency, especially at exercise with subaortic stenosis. This completes the picture of mild to moderate to severe, but two important additions in the pathophysiology of such disease have to be mentioned. Because of the nature of this stenosis, which is below the aortic valve, there is, even in mild, mind you, in moderate or severe, even in mild subaortic stenosis, the blood flow is not going in a wide column through the aortic valve. Now it's actually going in a narrower column through the aortic valve. This narrower column of ejected high pressure blood becomes like a water jet. It's a blood jet. So this blood jet is going to hit the aortic valve. And we know that if you hit something with a high pressure fluid jet, that surface will not continue to be normal. It will actually be injured. Injury will heal by fibrosis, and that structure is not going to be normal. So even in mild subaortic stenosis, one extra criteria here is that it may hit, or it will actually hit, the jet effect will hit the aortic valve, causing aortic valve damage on the long run, and then obviously aortic valve most likely regurgitation. And that's an additional pathophysiological effect that we see more specific to this disease. And it is an indication then to interfere even if moderate was not reached or severe is not reached, because now we have organ damage. And treatment in cardiology in general is to prevent any organ damage, any end organ damage. We do not want to see damage and then interfere. We want to interfere before organ damage has already happened. The other additional thing to subaortic stenosis, because the mechanism can involve the mitral valve leaflet as part of the cause of subaortic stenosis, then this mitral valve involvement may cause significant mitral valve regurgitation, both because of structural involvement and in the more severe form, it's actually because of significant LVH, significant EDP elevation, and then functional plus structural mitral valve regurgitation, and that will add to the pathophysiology another factor which is not good, which affects the pathophysiology in two ways: losing the cardiac output as mitral regurg back to the left atrium, and elevating the left atrial pressure, enlarging the left atrium, and possibly causing significant increase in pulmonary artery pressure with all of its effect. One last point in subaortic stenosis, especially if it's caused by inherited types of obstructive cardiomyopathies, then there could be atrial arrhythmias because of extra or accessory pathways, supraventricular tachycardias because of accessory or extra pathways causing the reentrant tachycardia. By this, I finish the pathophysiology effects of subaortic stenosis. I'll move to aortic valve stenosis in a minute. Okay, alhamdulillah, we just went over subaortic stenosis. We're moving now to aortic valve stenosis, the other part that can affect the other stenotic lesion that can affect the left ventricular outflow tract. So aortic valve stenosis is a stenosis in the aortic valve itself and its annulus. It's at the valve level, and obviously there is supra-aortic valve stenosis also. We'll take that at the end of aortic valve stenosis. Aortic valve stenosis can be of different structural causes. It could be because just of a stenotic valve, which is normal otherwise. That means it's trileaflet, the annulus is not hypoplastic. or it could be because of a bicuspid aortic valve, abnormally structured aortic valve, or it could be just because of hypoplasia of the annulus, part of other hypoplasia of the left side of the heart. Okay? So what is a mild aortic valve stenosis? A mild aortic valve stenosis is any systolic peak pressure gradient between the LV and the RV of less than or equal 40 millimeter mercury. Let's say less than 40, just for simplicity. Systolic gradient. Again, here, the LV pressure, if we chose the aorta to be 100, then our LV pressure here will be less than 140 systolic. Let's say we'll take a number, just pick a number, it's 130. It's just a mild elevation of the LV systolic pressure. So with such a mild elevation and normal systolic function, assumed normal, and at rest with no significant tachycardia, this gradient is going to be called mild. Because again, and this is I'm just going to eject this in, when we talk about gradients, especially between a squeezing chamber like a ventricle and another chamber, whether it's the atria or the artery, then we have to assume fixed points, function normal, at rest, no other issues, to call this number as mild or moderate or severe, because this number can be deceiving. I may get a low number if I have poor function, and I may get a higher number if there is tachycardia. So in all my talks, when I'm talking about pressure gradients, I am talking about rest situation, good function, unless I have specified differently. Okay, so a mean or a systolic pressure gradient of 40. Do we expect any left atrial pressure dilatation given that the LV systolic pressure is only mildly elevated? Obviously no, because we do not expect LV and diastolic pressure to be elevated. So the LA pressure will not be affected. It's going to be okay. Pulmonary artery pressure, if the LA pressure and the EDP are not significantly affected, not affected at all in this stage or in this mild form of aortic valve stenosis, then the pulmonary artery pressure will not be elevated. Left atrial size, will it be affected? If we said LA pressure was normal, then again, it will not be affected. Cardiac output will be also maintained. So no effect of mild aortic stenosis on cardiac output. LV hypertrophy, very unlikely to be seen. So LVH or LV change in size or LV systolic function decrease or LV diastolic function abnormality is unlikely or most likely not going to happen in mild aortic valve stenosis. Congestive heart failure, again, not expected, and arrhythmias not expected. And because it is the aortic valve and there is coronaries around it, we do not see coronary insufficiency or any signs of coronary ischemia in only mild aortic valve stenosis at rest. So this is simple. We'll go to moderate aortic valve stenosis, talking about a peak systolic gradient of more than 40, let's say 45, and we'll take it between 45 to 60 millimeter mercury. If we took the 60 as our maximum, plus the 100 in the aortic valve, then obviously we can start seeing mild to moderate LV systolic hypertension. So LV pressure here will be 160, that's significant. So we start seeing significant effect on the heart from starting with moderate aortic valve stenosis. Still, there will not be affection of the systolic function of the left ventricle because the LV will hypertrophy. We'll start seeing LVH here. It will be only mild, at maximum moderate, but most likely mild LVH, not even moderate. Since we are starting to see LVH, then LA pressure, because of possible elevated EDP, may be there, but it is unlikely, so it's a plus minus. Elevation of PA pressure, if this is a plus minus and it's a maybe and most likely, then again, elevation of PA pressure is unlikely in moderate aortic valve stenosis. Left atrial size and enlargement, again, if this is a plus minus, this is also a plus minus. We do not expect to see any effect of such moderate aortic valve stenosis at rest with maintained systolic function and maintained diastolic function with only maybe mild elevated EDP. We do not see left atrial enlargement. Cardiac output will also be maintained, so it will not be affected because, again, we do not expect loss of systolic function. We do not expect loss of diastolic function. We do not expect significant mitral regurg, and the stenosis is not yet severe, so the cardiac output should be maintained. Arrhythmias, congestive heart failure, if cardiac output is well maintained, unlikely, and the PA pressure is normal, it's unlikely to have any congestive heart failure. Arrhythmias are also unlikely. Could we see ischemia or signs of coronary insufficiency at rest? No, but if it is moderate with significant exercise, severe exercise, we may start seeing signs of coronary insufficiency because with exercise and tachycardia, the gradient will not be 45 to 60. It may jump up to 80 or 100. And then we are going into the severe forms of aortic valve stenosis. Again, I'm talking about rest situation. Left ventricular hypertrophy is there. Elevation of EDP, of LV EDP, is a possibility, but not a high probability. Talking more, do we expect to see any pulmonary edema in such patients? No, we do not expect to see pulmonary edema because the LA pressure is maybe affected, and even if affected, it may be only mildly elevated. So from a mean of 6, maybe mean of 8, 9, or 10, that would not cause pulmonary edema nor any right-sided effect like cor pulmonale. طيب. We'll go now to severe aortic valve stenosis, and here we're talking about gradients of above, systolic gradients of above 60 millimeter mercury. Usually we are talking about 75 to 80 millimeter mercury gradients. Here we have reached at rest severe aortic valve stenosis based on Doppler gradient measured by echocardiography or measured by direct measurement in the cath lab. So this is now severe aortic valve stenosis. Let's take its immediate effect. If this is an aorta of 100 and this is severe aortic stenosis, if we took, let's say, the 75 as the gradient, then the LV pressure here will be 175, maybe 180 millimeter mercury? Quite high. So when it's quite high, immediately we would expect left ventricular hypertrophy plus. If left ventricular hypertrophy has started and there is significant LVH, then ventricular stiffness, non-compliance, and elevation of left ventricular end-diastolic pressure is expected. So the EDP here will be high. We will start seeing high LV EDP. It will be elevated EDP, and with such understanding, but still we will see most likely a maintained systolic function. The left ventricle is a ventricle that has been created by Allah subhanahu wa ta'ala as a ventricle that holds or responds well to pressure overload. All of this is pressure overload. And the left ventricle has been created as a ventricle that responds well to pressure overload by hypertrophy and a better systolic function. If we leave that for a longer time, for sure, it may fail. And the failure usually will start because of the EDP elevation, not the systolic function loss. The systolic function loss is the last stage of such severe disease. So let's go back to our paradigm, like what we're talking about. If the EDP is elevated, there is LVH, and the pressure is high, would you expect left atrial pressure increase? Yes, we expect left atrial pressure to be increased. It will depend how high is the EDP, that will be how high the left atrial pressure. But the most common, it will not be elevated severely. It may be elevated between mild to moderate. And if we take that in consideration, then the pulmonary artery pressure may start now being affected, plus minus. It depends. If your left atrial pressure is affected severely, elevated severely, PA pressure will also be affected severely because of the high EDP, high LAP. But if it is affected only mild to moderate, then we will see a possible or more likely mild elevation of the PAP, maybe a moderate, but nothing much to cause any significant right-sided effect unless the EDP is extremely high because of a very long-standing aortic valve stenosis with significant LVH, significant elevation of the LV-EDP. Here we started to lose function, and then we will start seeing the bad effect on the right side or the significant effect on the right side. Left atrial size and enlargement, if it is moderately elevated LA pressure or more, then again it can be affected. Cardiac output in the resting stage where there is good systolic function and the EDP is not more than moderately elevated, then the cardiac output could be still not affected. But if systolic function starts to depress or EDP is more than moderately elevated, then the cardiac output can be affected. And again, I'm going to write here plus minus. LV, obviously we said there will be significant LVH. LV dilatation? No. If we reach to LV dilatation, then this is probably has been a way neglected disease to the extent that the hypertrophy has transformed into dilatation because of muscle loss, because of severe obstruction, severe effect on the muscle and ischemia, and now we are really losing muscle bulk from the LV, and this is really an extreme situation. Left ventricular, aortic valve stenosis, severe. Can it affect and cause congestive heart failure? Again, it's a plus minus. Yes, it can if we have systolic function loss or elevated EDP. If the EDP is not, the most common in non-neonatal presentation of aortic valve stenosis and in non-critical aortic valve stenosis that we actually do not see congestive heart failure at rest. The other issue, arrhythmias are also not usually seen unless there is severe LVH, severe elevation of ADP, left ventricular that is, or a very high left atrial pressure, then arrhythmias are plus minus. Here, I'm just going to add critical aortic valve stenosis. Critical aortic valve stenosis can follow severe or can actually be the presenting symptoms. So a neonate with a critically stenotic, severely critically stenotic aortic valve stenosis can present with a totally different pathophysiology. That baby may present in cardiogenic shock because of severe limitation of cardiac output, coronary insufficiency, and actually total body ischemia with all of the picture, the full-blown picture of cardiogenic shock. Patients may not show into cardiogenic shock, but will show congestive heart failure if it is severe to critical, not so critical to totally limit the cardiac output, but enough to prevent cardiogenic shock, but not to prevent heart failure if it is severe to critical. And in that situation, again, the patient may have a left to right shunt across the PFO, and the PDA may be open, and to maintain the cardiac output, the PDA will have to be kept open, and the patient will have to have some sort of a procedure to improve the left ventricular cardiac output. I think by this stage I have finished subaortic valve stenosis, aortic valve stenosis, and I'm just going to add a small point on supra aortic valve stenosis. It is not different from what we talk about here, except in one additional pathology or pathophysiology it can cause if it is more than mild, even moderate supra aortic valve stenosis. Even if it is only moderate with such a gradient, there is an additional effect that can produce more disease or more pathophysiology. What is that effect? You see, in supraaortic valve stenosis, the area above the stenosis will see the usual lower pressure, but the area below will see the usual higher pressure. What does this area below include? It includes the aortic valve, which is fine, but it includes the coronaries, the right coronary and the left coronary. You see? And these coronaries will be subjected to very high systolic pressure when it is moderate or severe, 160 to 170 for a long time. These coronaries are not meant to see such high pressure in systole nor in diastole. So what can happen is coronary artery wall changes and injury leading to coronary sclerosis or fibrosis, and this may add another picture to the pathophysiology, which is coronary insufficiency signs, especially in the post-operative period, because these coronaries cannot distend except with high pressure. And once this is relieved, these coronaries may show the ischemia effect, the severe ischemia effect on the heart. So that's one additional caveat about supra-aortic valve stenosis, coronary abnormalities can be associated with supra-aortic valve stenosis more than subaortic or aortic valve stenosis. So again, we may see other than just the sclerosis, we may see abnormal coronaries originating from the pulmonary artery or higher from a different artery in the aortic, from the aortic branches. A bit of a change. Again, I just want to remind you always that severe left ventricular outflow obstruction may cause the mitral valve to be abnormal, and usually it's abnormally regurgitant in the severe forms, or when the structure is involved in the LVOT phenomena, left ventricular outflow tract obstruction, and then we may have more regurg. By this, I have hopefully covered the most important points in pathophysiology of obstructive left-sided lesion of the subaortic, the aortic, and the supraaortic type. We are left with coarctation of the aorta. So we talked about pathophysiology left-sided. We covered the mitral valve, subaortic stenosis, aortic stenosis, the supraaortic stenosis. We'll talk about the final one, which is coarctation of the aorta. What is coarctation of the aorta? It's narrowing of the aorta, usually distal to the third branch or just at the third branch, which is the left subclavian, causing a significant narrowing in the diameter from the ascending aorta arch to the descending aorta. This stenosis will obviously cause a build-up of pressure on the area just before it and a lower pressure in the area just below it. And that's what we call the pressure gradient. And here again, in this kind of disease, we are measuring systolic peak pressure gradients. In aortic stenosis, for the sake of treatment, we do not wait for any pathophysiological effect. We just go by systolic peak pressure gradient as the number that will make us interfere and treat the disease. And usually we interfere even in just slightly mild or above mild by a bit to not allow any effect on the heart or the structures above the coarctation. So for a coarctation of the aorta to be called significant, then we are talking about a systolic peak pressure gradient difference between the ascending aorta or the LV and the descending aorta of more than or equal 20 millimeter mercury. Obviously, such difference, although mild, it's not going to cause, because it's mild, not although, because it's mild, it is not going to cause elevation of the left atrial pressure, nor elevation of the PA pressure, nor change in size of the left atrium, nor significant cardiac output limitation. May cause some LVH, very minimal, congestive heart failure, very unlikely, and arrhythmia, it's also extremely unlikely. Although we treat patients with such a gradient, we do not wait. First, it is a treatment that's more readily available, whether surgically or interventionally. And secondly, we know that there is no benefit to wait on. No benefit that you think it may go away by itself, like a mild stenosis on a valve, and no benefit that interfering now will change anything later on. In an aortic valve stenosis, you do not want to interfere early because you know you're going to interfere again and again. And that's why you allow it to go to the moderate to severe or severe form, then interfere to minimize intervention, and knowing that we are not affecting the heart so much. But in coarctation of the aorta, the likelihood of good treatment, 80% free from re-intervention, is more likely, and that's why anything that goes as a stenotic valve, as a gradient of 20 or more, we consider it significant and we treat the patients for it, either by intervention or by surgery. It's not part of my talk. Again, aortic valve coarctation can be a critical neonatal type presentation, or it can be a more of an infant or a child or an adult presentation. It depends on severity. It depends also on discovering it, because it's more of an insidious chronic type disease, and we usually we may not discover it easily because of missing a slightly decreased lower limb pulse, femoral pulse, or a slight difference in upper limb being higher pressure than lower limb, and so on, and because it usually doesn't affect cardiac function. Okay, this is mild. So what if it is more than mild? That means we're talking about a gradient of anything between 30 to 40. Here, this kind of a gradient can cause some effect. Usually left atrial pressure is not affected, pulmonary artery pressure is not affected, left atrial size is not affected. Cardiac output should still be well maintained to the lower body. Left ventricular hypertrophy is a possibility, so it can happen, maybe mild, maybe moderate. Congestive heart failure is an unlikely possibility, and arrhythmias are an unlikely possibility. If it goes or a gradient more than 40, let's say we have a gradient of 60 millimeter mercury, then this is quite severe aortic coarctation. If it causes significant elevation of the left ventricular end diastolic pressure, whether just because of direct pressure effect or because of associated aortic valve regurgitation or mitral valve regurgitation, we can have left atrial pressure elevation. Pulmonary artery pressure elevation is a plus minus, and it depends on the left ventricular EDP, left atrial pressure. If it's moderate or more than that elevated, then the PA pressure will be elevated. Left atrial dilatation is a plus minus. It only would happen if the left ventricular end diastolic pressure really became moderately to severely elevated, and then we'll start seeing the left atrial dilatation as well as the left atrial pressure elevation. Cardiac output should still be maintained to the lower body, unlikely to be affected if, like we said before, systolic function is normal, EDP is normal, and no other confounding factor, and in this severe form, it is still at rest. So cardiac output should still be maintained to the lower body. LV hypertrophy, LVH is a plus here. LV size, in terms of hypertrophy, it will be there. LV dilatation is unlikely unless we start losing function and unless it's a critical type stenosis, which I will come to. Arrhythmias are congestive heart failure with severe aortic valve stenosis is a remote possibility, but very unlikely. Arrhythmias are also unlikely. This is just a quick overview about coarctation of the aorta pathophysiology. But let's talk now more of the specifics of coarctation of the aorta. We said it may not affect your left atrial pressure, your PA pressure, unlikely left atrial size. Cardiac output, when we talk about cardiac output to the lower body, if it is moderate to severe, and let's say it is not a long-standing one, there will not be significant aortic vessel collaterals from the ascending aorta part and the arch to the lower body, if it is not a long-standing. And if it's starting with moderate to severe, our cardiac output may be affected to the lower body, and we may start seeing some signs of lower body poor perfusion, especially if it was severe. Luckily enough, this is an insidious chronic disease. So with time, almost all patients with coarctation of aorta will develop these collaterals, and hence the cardiac output will be maintained. The pressure gradient may not be changed, it will still be severe, yet the cardiac output can be maintained to the lower body, so we would not be seeing renal insufficiency, intestinal ischemia, lower limb ischemia, and other body ischemia. The only time when we see such ischemia, if there are poor collateral formation or the coarctation is a critical one and it presented as a neonatal presentation. Like aortic valve stenosis, critical presentation or neonatal presentation, then we will have severe lower body ischemia, and again a presentation of acidosis and cardiogenic shock because of poor cardiac output to the lower body and because of poor cardiac function in critical coarctation. The LV cannot eject, and it's because it's neonatal. There is not enough time to develop significant collaterals to offload this pressure overload from the left ventricle. And that's a totally different pathophysiology, which is a pathophysiology of low cardiac output, cardiogenic shock, cardiac muscle ischemia, congestive heart failure, core pulmonary and high PA pressure. If we talk about critical neonatal coarctation of aorta. This is in terms of gradients, structure size, pressures, and heart failures and arrhythmia. What other pathophysiological effect we see in coarctation of the aorta? We can see either associated, congenitally associated aneurysms of the arteries before the coarc, or actually acquired aneurysms because of dilatation and high pressure and wall injury of such vessels, especially in the brain. So patients with coarctation of the aorta may have brain aneurysms, arterial aneurysms, and these may rupture. So brain hemorrhage with all its pathophysiological effect can be a pathophysiological effect of severe coarctation of the aorta. Actually, when it's congenital, it's even can be with mild coarctation, and a pathophysiology of a brain bleed may be the presenting symptom or may lead to the presentation of CNS symptoms for a coarctation of the aorta. The blood vessels also become, before the coarctation, because of the high pressure, they will become sclerotic. So arterial sclerosis, especially the carotids, can be involved in the in coarctation of the aorta. Ascending aorta Aneurysms and dilatation because of wall injury, long-standing coarctation of the aorta can happen, or because of an association with an aortopathy, especially if they had bicuspid aortic valve with it. Aortic valve regurgitation with its effect, its pathophysiological effect, can be associated with coarctation of the aorta. One more additional thing, again here, the pressure is high in all of this ascending aorta and its branches, and we can develop coronary artery sclerosis and subsequent thickening and stiffening of those arteries and possible ischemia and actually even injury of their intimal surfaces, causing plaque formation, thrombus formation, rupture of the plaque because of the higher pressure here. And again, keep in mind that with coarctation of aorta, you have systemic hypertension of the upper body. And if you have systemic hypertension of the upper body, you can have all the effect of systemic hypertension on your eyes, retinal hemorrhage, retinal detachments, CNS events, rupture of an aneurysm, aortic valve effect, effect on the left ventricle, because now it's now sharing the pathophysiology of systemic hypertension, but it is upper body systemic hypertension. I hope by this I have covered in a reasonable way left-sided obstructive lesions, pathophysiology in the pathophysiology of congenital heart disease. I'll meet you again on a session, inshallah, with pathophysiology of regurgitant cardiac lesions. Till then, I'll leave you safe, inshallah. Assalamu alaikum.